Good morning. After 2 days successful section, I, Ranjita Jaina, faculty of Some Nursing College, Shiksha Anusandhan Deemed to be University, feel honored to welcome all the dignitaries, my colleague and participant for taking a keen part in this important event. I am sure that you all will feel enriched with knowledge after completion of this event. Without delay, let's start our session. This is the request for the participant. Kindly mute your audio and disable your video. If you have any query, then at the end of the session, we'll try to clarify it. So write your question on the chat box. Now, I welcome Madam Rupinder Deol. She is currently working as Assistant Professor, College of Nursing, AIMS Rishikesh. Madam completed her Bachelor in Nursing from Christian Medical College, Ludhiana, and Master in Pediatric Nursing from Christian Medical College, Vellore. Madam is currently a PhD scholar under National Consortium INC. Madam has 13 years of teaching experience. Madam recently finished her observership in NICU at Sick Kid Hospital, Toronto, Canada. Madam is member of many national and international pediatric and neonatal associations. She also has many national and international publications in her credit. I am glad to welcome you, Madam. Over to you, Madam. Thank you.
Thank you, Madam Ranjita. Good morning, everybody.
Good morning, Madam.
Are my slides visible and am I audible?
Yes, Madam.
Yes,
Okay,
ma'am.
so I'll start. So today I'll be discussing about prematurity, basically about the care and identification of premature babies and low birth weight babies. Already you have had previous sessions on the previous days in which few of the things would have been already discussed, like the care of normal newborns during COVID era, as well as NICU, which is also very important for the low birth weight babies. And yesterday, there must have been a discussion on neuroprotective environment also for the newborn. So I will be just touching these topics and I will be discussing about other things related to prematurity in detail. Moving on, we will discuss in today's in next 1 hour about why preterm care, what is the statistics of preterm in our country and globally, the basic care for the preterms, and how we can have a family-centered approach for the care of preterm babies. So, looking into the preterm baby survival and care around the world, each year about 15 million babies are born preterm, and their survival chances vary dramatically around the world. South Asia and Sub Saharan Africa account for almost two-thirds of the world's preterm babies, and over three-quarters of the world's newborn deaths are due to preterm birth complications. So, as you all know, that preterms are the babies who are born at less than 37 completed weeks of gestation as per WHO. Most premature babies, more than 80% of them, they are born between 32 to 37 weeks of gestation and so are known as moderate or late preterms. And many of them die needlessly for lack of simple essential care like warmth at the time of birth and adequate feeding support. About 10% of the preterm babies, they are born between 28 to less than 32 weeks, and then the remaining 10% are born before 28 weeks of gestation, and only these 10% which are born before 28 weeks of gestation usually require intensive care. So majority of the babies, they can be saved without the intensive care such as ventilation and other, just by the simple measures. So we will be looking into those aspects in the today's lecture. So before I move on to this, As you can see in this picture, that 135 million newborns are born, and 15 million out of them are premature babies. And the term babies which are born, they usually need the essential maternal and newborn care, which is this, which we usually give. And the babies which are born between 36 to 37 weeks, less than 37 weeks, they just need some amount of extra care. While the ones born between 28 to 32 weeks, they need care with certain for certain complications which may develop in them because of their lower gestational age. While less than 28-week babies less than them only may need intensive neonatal care, and they are less than 10%. So neonates with the birth weight less than 2.5 kgs or 2500 grams, irrespective of their gestational age, are termed as low birth weight babies. So they can be term, they can be preterm. But low birth weight, we can divide them into preterm, which are born less than 37 weeks, and small for gestational age. Small for gestational age is a baby who is born at term gestation, but the weight of the baby is less than 10th percentile. And for calculating the incidence rate of low birth weight babies, we usually calculate it with the formula number of live born babies with birth weight less than 2500 grams divided by number of live births into 100. So if we look into the important terminology, very low birth weight babies are babies who have a weight less than 1500 grams. Extremely low birth weight babies are babies who have a birth weight less than 1 kg or 1000 grams. Small for date babies are the babies who fall below 10th percentile for their period of gestation, and they can be assumed to be having intrauterine growth restriction. Appropriate for date babies are the babies who have a weight between 10 to 90th percentile, that is appropriate for their gestational age. Large for date babies have a weight higher than 90th percentile, and weight more than 97th percentile are again at high risk. And a preterm baby, as we have discussed, is a baby born with the age less than 37 completed weeks or less than 259 days. These babies are also termed as immature or born early or too small, too early babies. Term baby is a baby which is born between 37 to 41 weeks or 259 to 293 days. And post term is the one born after 42 completed weeks of gestation. So the late preterm is between 34 to 36 weeks plus 6 days. Very preterm is less than equal to 32 weeks, and early preterm is less than 28 weeks of gestation. And we have already discussed about low birth weight, very low birth weight, and extremely low birth weight babies. There are certain factors which affect the birth weight, which may include the maternal factors like malnutrition, anemia in the mother, high physical work, hypertension, malaria, low socioeconomic status, young age, parity, and birth spacing and educational status. As well as there can be placental factors like placental insufficiency, placental abnormalities, the fetal causes like fetal abnormalities, intrauterine infections, chromosomal abnormalities, and multiple gestations. So, low birth weight babies, as I have already discussed, can be preterm, which are less than 37 completed weeks, and they account for 1/3 of the low birth weight babies. And they can be small for date or IUGR babies, which are less than 10th centile of their gestational age, and they account for 2/3 of the low birth weight babies. So, how do we identify these babies, preterm babies? How do we differentiate them from the term babies? There are certain physical characteristics by which we may be able to identify a preterm baby. Like if we see the swole creases, usually these babies, preterm babies, have deep skin creases on the anterior 1/3 of the skin. Here you can appreciate the foot of a completely term baby in which the creases are very well formed. But in a preterm baby, the creases can be seen only in the anterior 1/3 of the skin. If you look at the breast nodule of the preterm baby, it will be 5 millimeters or less than 5 millimeters, not very well formed. But in a term baby, the breast nodule is quite well formed. Looking into the male genitalia, the scrotum does not have any rugae and testes are not descended into the scrotum in the preterm babies. Whereas in the term baby, the rugae are well developed and the testes are descended. In the female genitalia, the labia are widely separated, as you can see, not covering the labia minora, resulting in prominent appearance of the clitoris. And the preterm babies have a very pliable uh, ear cartilage. This ear cartilage, if you press it, it does not recoil back promptly on being folded, and it is very soft ear pinna. So, for small for date babies or intrauterine growth retardation babies, how we can identify them? This was about the preterm babies, okay? And then the other type is the small for date or IUGR babies in the low birth weight category. So we can identify with them using the intrauterine growth charts as well as with the physical characteristics. Usually, a small for date baby has a very emaciated look. They have very loose folds of skin, lack of subcutaneous tissue, and their head is bigger than chest for more than 3 centimeters. The difference between the head and the chest circumference is higher than 3 centimeters. In the intrauterine growth chart, so here you can see the x-axis is showing the gestation in weeks and the y-axis is showing the birth weight in grams. So you can see the preterm is the ones before 37 weeks of gestation, 42, less than 42, and post term it is showing above 42. And if we look into the as per their weight and the gestation, you can see that the small for date babies are the babies who fall below the 10th percentile, and appropriate for date babies they fall between 10th and the 90th percentile, and the babies which fall above 90th percentile for their weight as per their gestation, they are large for date babies. So you can see here clearly, you may be able to differentiate and appreciate this is a small for date or a IUGR baby, whereas this is a baby with appropriate for date baby. Okay, so you can see the baby has a very emaciated look, very less body fat, has loose skin folds. So you can easily differentiate by looking physically at the babies. Moving on to the care, what kind of care is needed and what are the differences between the care for all the babies and for the preterm babies? Mostly all the babies and especially those who are preterm, they have risk for hypothermia, that is low body temperature, which if happens can lead to increased risk of infections and mortality. And in preterm babies there can be a risk of increased risk of RDS also. And the babies, they also are at risk of cord and skin infections and neonatal sepsis, hypoglycemia and hypoxia. So for no, for the term babies as well as for any baby, normally for maintaining the temperature, we give thermal care, we dry the baby, we keep them warm, we put them in skin to skin contact, and we usually delay bathing. But in preterm babies, extra thermal care may be needed, like we may need to provide them KMC, we can put the baby caps or hats. We can put the mother and the baby under a blanket. We can put the baby under overhead heaters or in incubators to maintain the temperature. And for the cord and skin for prevention of cord and skin infections or neonatal sepsis, normally in all babies we provide hygienic cord care and skin care at birth, and we may do hand washing be used. But in preterm babies, we may need to give extra attention to infection prevention because they have low immunities, as we will be discussing ahead in the seminar, and skincare. And also, we can consider using chlorhexidine and emollients in the preterm babies. There is risk of hypoglycemia for that in feeding. We feed the babies within first 2 hours of delivery, and we promote feeding only the mothers will up till 6 months of age in the normal newborns. But preterm babies may need extra support for breastfeeding. So we may need to express and use a cup or tube feeding for these preterm babies. We may need to supplement the breast milk if there is an indication or there is lack of breast milk, which can be a risk factor for necrotizing enterocolitis in the preterm babies. And there, all the babies mostly have risk of hypoxia or low oxygen levels also. So normally in essential care, we provide neonatal resuscitation if the baby is not breathing at birth, and we provide bag and mask resuscitation with room air, which is sufficient for more than 99% of the babies who are not breathing at birth. But in preterm babies, we have to use this drug called oxygen very safely because it can cause many problems and retinopathy of prematurity and other complications. So we have to use a monitored oxygen using head box or nasal cannula, and routinely we can use pulse oximeters in the preterm babies. So why these preterm babies need extra care? Why we are separately discussing about these preterm babies? Because they are born before time. And when they are born, for example, here I have discussed if a baby is born before 34 weeks of gestation, the sucking and swelling process may not have been initiated in the baby. The baby may not have sufficient sucking and swallowing reflexes. So the preterm baby is more prone for feeding difficulties and also has a higher risk of aspiration. The immune system is not well developed, so they have a lower immunity and they have high risk of infection and neonatal sepsis, therefore. The lungs are immature and the surfactant may not be sufficiently formed in the alveoli, which predisposes these preterm babies to the high risk of respiratory distress syndrome. And these babies, due to their prematurity, the liver also is immature and liver is unable to metabolize the bilirubin adequately, which puts these babies at high risk of jaundice. And blood brain barrier is also not well developed to protect the brain, and so even a small amount of rise in the bilirubin can cross the blood brain barriers and can lead to other complications and connectors. And immature bone marrow can lead to anemias of prematurity. They lack brown fat in their body, and they lack, as we have seen, subcutaneous tissues in their body, so they are unable to maintain the heat and warmth also, and they are at higher risk of hypothermia. And once a baby is hypothermic or the temperature is low, the baby will start utilizing or will need more energy to maintain the body temperature. And this means more energy consumption means more need of nutrition, more calorie burn up. So these babies will be at higher risk of developing hypoglycemia because they are, as I have already told, they also don't have proper sucking and swallowing reflex, and they may be already facing issues with feeding. So this hypoglycemia again can lead to, and all these can lead to hypoxemia also, and this will be a sequel, and the preterm baby may land up into several complications if we initially a proper nursing care and observation is not done for the preterm baby. So these babies need extra care. What can be the issues during the delivery? When we are suspecting that the mother is going to deliver before the gestation, we should try to transfer the mother to a well-equipped center before the delivery itself. Because in utero transport of the preterm baby is the safest mode of transport. Skilled personnel should be available there for resuscitation, and prevention of hypothermia should be our topmost priority to prevent the sequelae which I have just discussed with you. And we should always consider early intubation, early initiation of continuous positive airway pressure, prevention of hypothermia and hyperoxia in these babies once they are born. So, neonatal resuscitation, basic resuscitation through the use of bag and mask or mouth to mask, tube and mask will save 4 out of every 5 babies who need resuscitation. More complex procedures like endotracheal intubation are required only for minority of the babies who do not breathe at birth and who are also likely to need ongoing ventilation. So recent RCTs also support the fact that ventilation with room air is equivalent to using oxygen, and unnecessary oxygen has additional risks. So for the preterm babies, basic resuscitation for preterm babies reduces the mortality by about 10% in addition to immediate assessment and stimulation of the babies. So the problems which we should consider during resuscitation is that the baby may be having a compromised intrauterine environment. That is why the baby may have maybe the mother may be delivering preterm baby. The lungs can be immature, putting the baby already at the risk of respiratory distress. Immature blood vessels in the brain, thin skin and large surface area predisposing the baby to higher risk of hypothermia, and these babies have increased risk of hypovolemic shock because even a little bit of shift can in the babies. So we should prepare for a high risk resuscitation. Resuscitation should be very gentle. Small bags appropriate for the preterm baby should be used for positive pressure ventilation. We should consider using CPAP in these babies, and we should focus mainly on prevention of hypothermia in these babies. I will not be discussing resuscitation in detail because that is in itself is a topic which needs a complete day. But we should keep in mind the dangers of putting the baby or exposing the baby to higher levels of oxygen because these can lead to chronic lung disease, retinopathy of prematurity, necrotizing enterocolitis, and preventricular leukomalacia in the preterm babies. So when should we hospitalize a low birth weight baby? If the birth weight of the baby is less than 1800 grams, and if the baby has a gestation less than 34 weeks of gestation and is unable to feed, or it is a sick neonate, so then we should consider the babies for hospitalization. But if a low birth weight baby, irrespective of their birth weight and gestation, if they seem to be sick or if they are unable to feed, then we should not hospitalize. We should hospitalize them immediately. Essential and extra newborn care. These practices are essential for the full-term babies, but for premature babies, missing or delaying any of this care can rapidly lead to deterioration and death. For all the babies at birth, minutes count. So for preterm babies, thermal care, maintenance of normal breathing, providing feeding support, and preventing infection is even more important. Moving on to the temperature control. The problems which can be seen in the preterm babies are higher surface area to body weight ratio, low glycogen stores, low subcutaneous fat. So we have to teach the mother how to monitor monitor the temperature of the baby, and we have to focus on warm chain maintenance. In the hospital, again, in the hospital itself, we can initiate skin to skin method and KMC, and we should keep the room warm where the baby is kept. Baby should be kept warmly wrapped. Heater or water filled mattresses can be used. Radiant warmers can be used. Air heated incubators can be used for keeping the babies warm. And also, when the baby is under radiant warmer, the baby may lose heat by evaporation, conduction, and by convection, air convection. So, to prevent that heat loss, we can put a plastic sheet like this over the radiant warmer, which is known as cling wrap, which helps in preventing the heat loss and maintaining the temperature. Thermal comfort should be provided. Pre-warmed open care system or incubator should be available. Even the instruments which we are using for the baby, if we are touching our the baby with the hands, we should rub our hands, because usually when we enter a NICU or we are touching a baby, we usually wash our hands in between the babies. And so first we should rub our hands together and warm our hands. Then only we should touch the baby. We should not give a cold touch to the baby. Whatever sheets or even the stethoscope or other articles, whatever we are using for the baby, they should be pre-warmed. They should not be cold to touch, because again, if we touch the baby with those colder things, then the baby may lose heat. We should keep the incubators, radiant warmers, or the baby cots away from the doors, open doors, or from the cooler walls, or away from the windows also. And care should be given in a thermal neutral environment with a servo sensor gear to maintain the skin temperature at about 36.5 degrees Celsius. So, thermo neutral environment is that environment in which the baby has to spend 0 calories, means does not need to spend any calories either to maintain the temperature. So that is a thermo-neutral environment. And in preterm babies, we can also use, as I have told, some oil to reduce the convective heat loss and evaporative weight loss. So that was all about temperature maintenance. Moving on to the feeding support, the other important aspect of maintaining or caring for the preterm babies is feeding support. As I have told, they have very poor access. So we should try to initiate breastfeeding early. And premature babies, they benefit from immunologically as well as developmentally. The short-term and long-term benefits compared with formula feeding are well established, with lower incidence, improved neurodevelopmental outcomes in the preterm babies. And the mothers, it has been found that the milk of the mother of a preterm baby has different components which are essentially required for the preterm babies as compared to the milk of a mother of a term baby. So it is very important, and it will meet the nutritional needs of the baby efficiently. Most premature babies require extra support for feeding, like with the help of a cup or a spoon or some other device such as gastric tubes, orogastric tubes, or nasogastric tubes. In addition, the mother requires support for expressing milk, and where this is not possible or mother is unable to give her milk, donor milk may be considered. Extremely preterm babies who are under 1 kg and babies who are very unwell may require IV fluids or even total parenteral nutrition. And then when we are putting them on IV fluids and TPN, then we should be very meticulous about the volume and the flow rates at which we are giving fluids to these preterm babies. WHO does recommend supplementation with vitamin D, calcium, phosphorus, and iron for very low birth weight babies, and vitamin K at birth for low birth weight babies. So this chart shows the feeding volumes and the frequencies. If the baby is less than 1200 grams, we can start the feed at 10 to 20 ml per kg per day, and each day we can increase the volume by 20 ml per kg per day to a maximum volume of 180 ml per kg, and the frequency will be every 2 hourly. For the babies who weigh between 1200 to 1600 grams and also above 1600 grams, we can start the volume at 60 ml per kg per day, increase by 30 ml to a maximum volume of 180, and the feed can be given 2 hourly or 3 hourly if the baby is little bigger, but usually we prefer giving every 2 hourly. And to be more specific, if the babies are below 1200 grams and their gestation is less than 30 weeks, we can try gavage feedings if the baby is not sick. Otherwise, we have to start initially the IV fluids, and once the baby is stable, we can introduce gavage feedings, and slowly we can shift to katori spoon feeds over the next few days, and later on to the breast feeds as the sucking and swelling reflex improves. If the baby weighs between 1200 to 1800 grams and the gestation is between 30 to 34 weeks, these babies may need IV fluids if they are sick. Otherwise, we can initiate gavage feedings initially, and then katori spoon feeding after 1 to 3 days of gavage feeding, and then we can shift to breastfeed as soon as baby is able to suck. If the weight is more than 1800 grams and gestation is more than 34 weeks, We can start with the breastfeeds and Katori spoon feeding if sucking is not satisfactory on breast, and then we can shift to breastfeeds as soon as possible. The feeding schedule should be like we can begin with 60 to 80 ml per kg per day and increase by 15 ml per kg per day on an average to a maximum of 180 to 200 ml per kg per day. First feed should be given before 2 hours of age, and then every 2 hourly the feed should be given. So we can give feeds through gavage feeding, through Katori spoon feeding, and ultimately we can put the baby on direct breastfeeds. And after we reach to the actual level of 180 ml per kg per day, we can add uh, if the baby is under a radiant warmer, we can add about extra 20 to 30 ml per kg for those infants. And babies who are under phototherapy, they can be given an extra 15 ml per kg because they will be having more of the evaporative heat losses and fluid loss through that. So this is yet another table which is showing the same increments by 15 ml. So how will you know that the nutrition which is given to baby is adequate? You can monitor the weight of the baby daily. Normally, most of the small for date babies, they sometimes they do not lose weight in the initial days. Otherwise, the babies may lose 1 to 2% of the weight every day initially. Cumulative weight loss is 10%, which is more in preterm babies. Then they may regain weight by 10 to 14 days and gain weight up to 1 to 1.5% of birth weight daily. Excessive loss or inadequate weight may be due to cold stress, anemia, poor intake, and sepsis. The supplements which can be given to the babies include vitamins like vitamin K, which can be given 1 mg at birth, and then vitamin A 1000 international units per day, vitamin D 400 international units per day, iron oral 2 mg per kg per day for 8 weeks of age. From 2 weeks of age, the vitamin A and vitamin D can be started. Then you should be aware of the danger signals, which should be, and these should be taught to the mother also for early detection. Like if the baby refuses to feed or is hypothermic, or there is tachypnea, grunt, gasping, or apnea, or if the preterm baby has seizures or vacant stare, or if you observe any kind of abdominal distension, bleeding, icterus over the palms and the soles. Moving on to the transportation of the low birth weight babies. During the transport, we should try to provide and maintain the warmth of the newborn, of the preterm baby, proper life support measures. Try to transport the baby in skin to skin contact with the mother if possible, and a proper referral note should be there. Infection prevention. Infection prevention, as I have told, that these preterm babies have a lower immunity and at a higher risk of catching infection. So infection prevention is very important. Clean birth practices can reduce the maternal and neonatal mortality and morbidity from infection-related causes including tetanus. Premature babies, they have a higher risk of bacterial sepsis. Some kind of emollients can reduce the water loss, dermatitis, and risk of sepsis. Many trials have and effective clamping of the umbilical cord, waiting to cleaner under the cord stop sitting while skipping below the level of the placenta can preterm basis reduces this intracranial need for transfusions as well as anemia. So hand washing had the baby their if required, and decreasing the exposure to the others is very important. Let's discuss why and what it is having first. And that they must have, you must have learned that the sensory systems they develop in a certain order. and if you enhance system development, be altered to compensate or adapt. So, in the developmentally supportive aids, maintaining temperature, therapeutic touch, appropriate in ICU or environment, and appropriate noise control measures, taste through the breast, which gives almost of stimulation the baby. All these are very important. Gentle rhythmic stimulation, like touch, massage, cuddling, stroking, but another soothing audio stimuli can be given in the form of family voices, or light music, visual input can be provided. And regarding immunization, there is no change in the immunization. The same vaccines can be given as it is given in the term baby. Move on to the prognosis. Mortality is inversely higher the birth weight. The higher the gestational age, the less will be mortality. And it is directly related to the severity of the complications. And long-term prognosis depends on the gain on birth weight, gestation, and the severity of complications. In long run, preterm babies may develop developmental disabilities, cerebral palsy, mental retardation, sensory impairment, ADHD, learning disorders, behavioral problems, retinopathy of prematurity, lung diseases, poor growth, congenital anomalies, risk of child abuse and neglect. Also, when caring for the preterm babies, we should ignore the mother. We should pair the parents to see their friends. We should orient them to the NICU, encourage visit by the parents, encourage parental interaction with the preterm, assist in expressing their feelings of guilt, inadequacy, involve in reassure activities, promote the parent-child relationship, and prepare them for discharge. Thank you so much.
Thank you. Very informative, interesting, madam. Dear participant, if you have any query, then you can directly ask to madam. So there is no query because, madam, you present so nicely that it is clear to all. So, madam,
Thank you
one
so
student
much.
asked question. Excuse me, madam. One student asked
Yes,
question.
yes.
Is there any complication for post-term baby?
Yes, postpartum babies have their own complications, so that is a entirely different topic. But definitely, they have complications, and their physical features and the care also will vary, and their requirements also vary because they have been for a longer time in the womb.
Hopefully, Sayantanity.
Yes, ma'am.
Thank you. So, thank you, madam, for an excellent and informative session. Thank you, madam.
Yeah,
Moving to the
because
next
postpartum babies, no, they
present.
are. Yeah, sorry to interrupt. Babies, they are big babies. So during their delivery, they may be passing through the birth canal. So more birth trauma can occur, like fractured bones or nerve injury. Even they have more dystocias, and their weight gain and the other feeding requirements and the glucose levels, they also will vary. So it is, if we discuss it, it will be means it needs a little detailed discussion on that.
Yes, ma'am. Thank you, ma'am. It is really very informative and excellent presentation, madam. Moving to the next presentation, I welcome respected and most distinguished persona, Madam Geeta Rani Naik. She is currently working as assistant professor at College of Nursing, AIMS, Bhubaneswar. Madam completed her bachelor in nursing and Master in Pediatric Nursing from Barampur University. Madam has almost 24 years of experience and she has various national and international paper publication in her credit. Madam has been awarded with Dr. Sarvapalli Radhakrishnan Lifetime Achievement Award by IRDP Group of Journal, Chennai. Madam is member of many national and international pediatric and neonatal association. I heartily welcome you, ma'am. Over to you, ma'am.
Thank you, Ranjita. So, good morning to all. So first of all, I would like to give thanks to the organizer, so the Dean of Some Nursing College, and also organizing secretary for giving me this opportunity. So, rightly you have chosen this topic. So, every year we are celebrating, observing the newborn week, and we are awareing everybody, and we are giving more information regarding the newborn care during these sessions. So today I have assigned with the topic like perspective on promotion of KMC. So let me share my slide. So is it visible? Hello.
Yes, madam. Yes, madam. Visible.
So my topic is you have already chosen this webinar series as strategy to strengthen newborn care survive healthy future. So my the topic is perspective on promotion of KMC. So before coming to the KMC, so I would like to focus on the global burden, how this burden occurs, and mostly this if we see that live births, so in India around it is 26 million. And this proportion of the global bodies around your 20%, and it rank or occupies a rank in number one. Similarly, the low birth weight babies, India also around 6 to 8 million babies born as low birth weight babies, and in the world it rank as one. And if we come to the global burden of neonatal death, India's proportions. So India constitute around 30% of neonatal death of the world. So that's why this is very much alarming thing. So nowadays, because of different interventions, different awareness and all, so this neonatal death has reduced to many extent. But if we see then the death, neonatal death, how it occurs, one two-third principle is there. So two-third infant deaths that occurs in the first month of life. When the baby borns, two-third of the infant dies in the first month. And out of that, two-third die in first week. And among these, two-third die in the first day. So that's why it is very much important thing. These babies, most of the babies die in the first day. So what are the reason for death? Mostly we have to prevent the neonatal death. And for this only we are organizing this kind of webinar series and all. So what are the causes? And this mostly the low birth weight babies and these premature babies are the more important causes for neonatal death. If you see the problems of low birth weight babies, so many problems are there. So out of that, this hypothermia is one of the important problem of low birth weight baby and premature babies. So many I have listed. So hypothermia, hypoglycemia, apnea, infection, prolonged NICU stay, decreased bonding, mortality, and poor weight gain, hypoxia. And out of this, I'll just focus on hypothermia because my topic is promotion of KMC. So hypothermia is a silent killer. If you see, then it's a silent killer. If you are not taking care properly and immediately not identifying, then definitely newborn will land up into the death. So that's why it's very much important thing that we should see and deal the hypothermia. So in hypothermia, so what are the actually what is hypothermia and how to deal with this hypothermia and all. So that is also important thing. So this, if you see the causes of neonatal death, so prematurity is one of the important thing. Then this hypothermia, so why it is important thing? So this effect of hypothermia is very much grave. So this hypothermia, if you see then the mortality and morbidity rate, if the baby is on hypothermia, so then the mortality and morbidity rate also will increase. Like hypoglycemia, it may cause metabolic. I think my previous speaker has also told ki how this hypothermia causes hypoglycemia and all, because the oxygen consumption also will increase, metabolic rate also will increase. So that's why there is a hypoglycemia, metabolic acidosis, poor weight gain will be there. And there is also myocardial dysfunction, shock also will be there, and neurological injuries will be there. And baby may develop sepsis, hypoxia, apnea, and persistent pulmonary hypertension. So these are different kind of problems we will land up. So suppose the baby is admitted with low temperature, then we see that one study has published, and it is saying that the mortality rate will increase by 28%. And this late onset sepsis also will increase by 11%. So that's why, so this is very much important thing. If the baby is in hypothermia, so the mortality rate increases by 28%. Then other kind of mortality and morbidity also will increase. Another study tells that as the baby's temperature decreases, the mortality rate also increases, and the neonatal also increases. Like baby have severe injuries, and bilateral pulmonary dysplasia also will occur. Severe retinopathy of prematurity will be there. Then we have to keep the baby in ventilators. Severe necrotizing encephalitis also may happen, and late onset sepsis also will be there. So in 2015 journal it is published like that. So that's why it is very much important thing. And simple interventions. So simple interventions will increase the survivability, and it will decrease the mortality and morbidity. So UNICEF has published like intervention to prevent hypothermia will lead to decrease in mortality and morbidity by 18-42%. So simple measures can decrease the hypothermia up to 42%, and the survivability of the baby will improve. That's why it is very much important thing. So why this is important thing to maintain the normal temperature, and what is the neutral thermal environment? That is important thing. Everybody should know that what is the normal thermal environment. If you are decreasing, or if you are not maintaining that, or babies are, if the babies are developing hypothermia, then what will happen? So neutral thermal environment means a range of environmental temperature in which an infant can maintain normal body temperature with least amount of basal metabolic rate and oxygen consumption. So if you are maintaining the normal temperature, so definitely the metabolic rate and oxygen consumption will less. And if the baby, so usually the normal temperature of the newborn baby is 36.5 to 37.5 degrees Celsius. And we know that if the baby's temperature is less than 36.5 degrees Celsius, that is your hypothermia. So as the baby is not maintaining normal temperature and the temperature decreases, so basal metabolic rate will increase and oxygen consumption will increase. So some thermal neutral temperature zones are there. These are few zones. So actually the ideal temperature will depend upon the weight and days of life and gestational age also. As the gestational age decreases, the temperature requirement also will be more. The thermal zone also will be. That will also the requirement of the temperature in the first day, second day, third day, fourth day, like that. You can see. So if the weight is then 1200 grams, so definitely we have to maintain 35.0 degrees Celsius. This much temperature is required. And like that, 1200 to 1500 gram, then 1601 to 2500 gram, like this. So as the day increases, so maybe the temperature requirement also will be decreased. So 33, we can just imagine that our room temperature is around 25 27, 28, and during this winter season, it is very less. So that's why it's very much important to maintain this thermoneutral environment for the baby. And so different ways of heat losses are there. Like already some of them have already discussed. So like conduction, convection, radiation, and evaporation. So these are the different ways of heat loss. So we have to prevent this thing. Then only we can maintain the normal temperature. And mostly this KMC is basically it is required for the mostly the stable low birth weight babies. These stable low birth weight babies, so usually and mostly preterm babies also. So these babies are more prone for developing hypothermia. So what is the reason for that? So why we should go for KMC and how it can helpful? So why these preterms are at higher risk? Because they're having less brown fat. So we know that this brown fat will help for the generation of heat in case of your newborn babies, and it is very less in case of if the baby is a premature baby, low birth weight baby. Definitely the brown fat is very less, and the baby is having larger surface area, and the skin immaturity also is there. So the skin is very thin, and this high transepidermal water loss also will be there. So that's why these babies need more care, and these are the reasons for developing hypothermia in premature babies. And if you see that this brown fat that contributes 4 to 10% of the fat, and main source of non-shivering thermogenesis. Usually, adult there's a very cold shivers and the heat generation occurs, but newborn baby it is not like that. The thermoregulation center, the hypothalamus is not so much developed. It is immature, so that's why this brown fat contributes the non-shivering thermogenesis. So once they feel cold, then this non-shivering technique helps to generate the temperature or the heat generation. And like if the baby's temperatures are the gestational age is around 26 to 30 weeks of gestation, then it cannot be also detectable. That's why we should identify it very much early so that we can manage the babies. More per unit per kg weight compared to adult. If you are comparing to the adults, then their body surface area also like more. So that's why the heat loss also is more. And usually the premature babies doesn't adopt the flex posture. So sometimes they adopt the extended posture. So if they are adopting extended postures, then that will also expose more body surface area and more heat loss also will be there. So skin changes also like their skin is very much thin, and more thinner epidermis is there if we compare with the adults. So they are having very much thinner skin, and that's why it is less hydrated and has reduced natural moisturization factor, and that's why also increased insensible water loss also is there, and they are also more prone for injury. Increase insensible water loss is also. So that's why, like, how to prevent these things, that also we should know. So this KMC Kangaroo Mother Care is a comprehensive and low-cost method of care for the stable low birth weight babies. So usually, this many ways of preventing hypothermia is this. I'm not going to deal with that. The warm chain is there. Different other concepts are there. So here I'm going to focus about the KMC and how it is helpful and how to prevent. One of the important aspects is prevention of hypothermia as well about the KMC. Why we should promote this KMC. So, coming to the history, if we come to the history, how it has developed and how this concept has come. So, you might have seen, like Australia, these kangaroos are seen, and how they are carrying their babies in their pouch. And in that way, so they are maintaining the warmth as well as the growth also increases, and the baby takes feeding and all. So that's why from this concept has come. So let me tell you about the history of this Kangaroo Mother Care, how this history has come. So previously in the year, like this before this, you can say. So people's concept is that just carry next to your skin, breastfeed whenever it is hanging. So if you say that 2000 times, so that time just that you have to carry the baby next to your skin and breastfeed whenever it is hungry. But after that, the concept is changed, like 1660 AD. So it is told that the people's concept developed that breastfeeding is undignified. So in the public, when they are feeding the baby, so they feel like it is undignified act. So that's why what they told, hand it over to the wet nurse. So wet nurse is a nurse like she's having a child, or she can feed the other babies. The babies, the mother is wet nurse means she can feed other babies. If sometimes nowadays also the policies are there, like if any mother is HIV or mother is dead, then sometimes we are handing over to the wet nurse. The wet nurse will breastfeed the babies. So that concept developed. Then 1850 AD, so these wet nurses are low class. So they thought that these people are belonging to low class people and have an undesirable influence on the child. So get a good experience nanny to bottle feed, eat cow's milk, and win it onto a cup as soon as possible. Then concept changed around 1850 that we have to get a good experienced nanny to bottle feed the cow's milk. So nanny will help to bottle feed the baby, and that is cow's milk. So that time the importance of breast milk was not so much established. So they were giving, but gradually the concept was changing. So after that, the cup and spoon they used to win. Then around 1930, so cow's milk is unsuitable for the baby. They thought that is unsuitable. So many studies are going on that it must be bottle fed on a special infant formula. Then 1950, bottle feeding at all hour is bad for the baby. Follow a strict routine, its own room, and ignore ice at. It has revolved round, and again it has come to like this. Now they established that bottle feeding is unsuitable and a strict timetable is nonsense. Babies don't like being alone, and crying is stressful. So just carry it next to your skin. So you can see that whatever the concept was there in the 2000 BC before Christ, the same concept now again came in the after 2000 years of like Christ anatomy or this AD. The same concept comes. So just carry it next to your skin. So that means this skin to skin contact. And when we're carrying the baby next to our skin, so definitely so many benefits are there, and breastfeed it whenever it is. So from this history, we can say that this is the history of baby care. Then the origin of this KMC has developed like Dr. Edgar Ray Sunberia in 1978. So they have devised this thing, or they have developed this concept. So it is an alternative to incubator and severe infection. So he is a person from Colombia, Bogota. Then later on, so they have realized more other advantages, and they further other people like Dr. H. Martinez, 1979 to 94, and L. Navarti, 1980 to 1994, at the Institute Materno Infantil in Bogota. They have just promoted this KMC or kangaroo mother care, you can say. And nowadays, like a kangaroo foundation research teams are also there. Many international conferences, and they are also increasing the awareness about the KMC. So, what is this KMC? Why we should give? What are the benefit of this KMC? We'll just see. Like, what are the benefits to the baby? So, if we'll talk about the benefits of the baby, so it will give warmth 24-hour. So KMC is acting just like a best incubator. You can see the mother, like how the mother is carrying the baby in the KMC. And multimodal stimulation also will give. So I think you have already covered the developmental supportive care. In that, multimodal stimulation is like your the gustatory development stimulation, the auditory stimulation, visual stimulations, and auditory stimulation. So by this, like if the mother keep the baby close to her, then the baby can smell the mother's milk also. Like olfactory stimulation can occur premature babies, and the baby can listen about the mother talking, and baby can also visualize. So visual, auditory, olfactory, and gustatory stimulation also. Baby can taste the breastfeeding, and tactile stimulation also will be the mother will hold the baby, the touch and all the gentle touch. So all this they can help to develop the baby. So mostly premature baby needs this multimodal stimulation is required for the maturation of the baby. So that's why this games you can say that it's developmental supportive care. Next is reduces infection. So many studies have been seen that okay, if you are putting them in the games of infection is because it may temperature neutral temperature is the temperature alert point the IQ because throughout the then apnea development, as I was telling, like if the baby is hypothermic, then the basal metabolic rate reduces and consumption also becomes more. So oxygen consumption or oxygen requirement also is there, apnea also is reduced. Then baby have physiological stability, the respiratory rate, the heart rate, the oxygen saturation, all the stability also is achieved through this game. So these are some of the benefits to the baby. And we'll move to the benefits of the mother. So once the mother, suppose like baby is very premature and weight is very less and low birth weight baby, sometimes we have to put the baby in the NICU. The mothers are very much in and more tensions are there. So here it increases self-confidence of the mother. Once the mother holds the baby near to, sometimes if you are transferring the baby to NIC, sometimes the mother is not able to see or visualize her babies. If the mother is again mother has undergone the cesarean section, the mother may not able to see the baby. So in that case, so if the mother is again nowadays most of the NICUs they are allowing, and they are especially they are providing the KMC inside the NICU also. Confidence increases and better maternal and baby bonding. So separate to the baby from the mother, then this bonding cannot establish, and again it will hamper development. So that's why it is best move, or you can say that best way of establishing maternal and baby bonding. Then reduce hospital stay. So this infection rate will this sepsis also will reduce. So and this physiological stability. So that's why definitely KMC will reduce the hospital stay, and it will give you the mother the satisfaction that my baby is with me. I'm able to visualize my baby. I'm able to care my baby. So day to day development or day to day like increase, or you can say that close contact between the mother and the baby, and mother get a kind of satisfaction. It is very much economical. Suppose low birth weight baby. So again, it's a very much challenge, and it's very you can say that the cost of hospitalization is more. When we are putting the baby inside the NICU, the baby has to undergo many procedures, and many kind of procedures will be there, and more cost will increase. But if you are putting the baby, it is a simple and cost-effective method or procedure. So it doesn't require any kind of money, but in the return, so it gives you more benefits. So that is very much economical. And successful breastfeeding also establishes. So if you are putting the baby in this, so there is a successful breastfeeding also establishes. That's why it is also the benefit to the mother. So moving to the benefits to the family. So what will be the benefit to the family? It is not giving the benefit to the baby or mother, but as well as it is giving to the benefit to the family. So it saves money. So in terms of hospital cost, so in terms of like your, it promotes the exclusive breastfeeding. That's why the artificial feeding also decreases, and infection rate decreases. And in future also, baby may not have morbidity and mortality also is decreased. So that's why it saves money. Then earlier discharge. Though if the baby is in the NICU or in the hospital post partum or then definitely it will increase the discharge, or it reduces the hospital stay, earlier discharge. Then father returns to the work early. Suppose baby is sick frequently, baby is getting sick, then father also cannot return back to work, and the economical condition also will happen. Then better follow-up, better IQ, child abuse and abandonment. Sometimes child abandonment many times we have seen, and child abuse also we have seen. So if the mother is putting the baby in the KMC, so all these things are also reduced. So it is a social problem. We can say that you can reduce some of the social problems. Then breastfeeding success and healthier baby. So these are the benefit to the family. So KMC saves them money. So artificial milk should not means it will not require the artificial milk, because the KMC will promote the exclusive breastfeeding, and antibiotic and medication also will reduce. Hospital stay also reduce. Healthcare beyond neonatal period, that also will increase. And health personnel, uh, we should not spend more money on health personnel, and we can maintain. And so in that way it saves money. So we'll go to the components of KMC. So 3 components are there. So skin to skin contact attached to mother's chest 24 hours a day, upright position, breastfeeding. Then early discharge, or some centers where ambulatory follow-up or facilities available. So these 3 options, components are there. So first is the skin to skin contact. Second is exclusive or nearly exclusive breastfeeding, and early discharge. So components of kangaroo mother care. So I think everybody knows, but still, like the components, it comes like a kangaroo position, skin to skin contact. So in the skin to skin contact, so you can see that how the mother is holding the baby. So the mother should wear a front open gown. Everybody knows this thing, but still, like every mother should open wear the front open gown, and it is a skin to skin contact between the baby and mother. Specialized kangaroo bags are also available. Otherwise, we can just remove the clothing from the baby's chest, and the mother's chest and baby's chest should be in contact, and mother's abdomen and baby's abdomen also should be in contact. Then baby's head should be turned to one side, and baby should wear cap, nappy, and socks. These 3 things baby should wear, and the front should be open, and direct skin to skin contact between the mother and the baby. And the head should be turned to one side, and legs should be flexed like a frog position. So this is the kangaroo position. So the skin to skin contact between the mother's chest and the baby's chest, legs should be flexed, head is turned to one side. So this is the kangaroo position. So we have to provide this kangaroo position. So these are the bags also. In this way, the mother can carry. After putting the baby in that way, so if you the bags are available, then you can put the baby inside the bag. Otherwise, we can just wrap the baby, and first we have to wrap the baby with a cloth, then mother and baby with another cloth. Or sometimes binders are also available. We can use the binders also to protect the baby and the mother. This is the kangaroo position. And in this position, so like the minimum is 1 hour and maximum is 24 hours. The mother can provide the KMC. And if the mother is sick or mother is doing her activities, then father and grandparents also, they can provide the KMC. And second thing is the exclusive breastfeeding. So in this position, so baby can take the feeding. So while the mother is doing her work, or Like sometimes in the NICU and all, reclining chairs are available. We can put the mother in the reclining chair and put the baby in KMC position. And in this position also, the baby can breastfeed. And we have to promote the exclusive breastfeeding. So till 6 months of life, the baby has to take only breast milk, not other things. Exception is the vitamins and medications and all if it is prescribed. So not a single drop of water should be given. The exclusive breastfeeding should be given. Third is the early discharge. So this is a component. So again, it will give the infant and mother diet support like medical, emotional, physical, psychological, without separating the diet. So, like immediately after the birth, also we are putting the baby and mother skin to skin contact. So nowadays, like your breast crawl also is allowed. It is promoted. Breast crawl once the baby is delivered, baby will automatically, so naturally, baby will crawl and baby will reach to the mother's breast. And we have to immediately after birth, we have to dry the baby. Everything should be done on the abdomen and skin to skin, early skin to skin contact should be given. It is an important thing nowadays. The new concept is there. We should not separate the baby and mother. Like previously, they used to receive the baby in a tray and putting the baby in separately or putting the baby in the radiant warmer and all. This concept is not there because skin to skin contact will have so many more benefits, as we have already seen that if the mother sees the baby and touch the baby, definitely the initiation of breastfeeding also starts, improvement occurs, establishment of the bonding also will be there. So emotionally mother will be attached, physically like separation of placenta also will be quicker, and pph also will decrease. So many more benefits are there, like the psychological also mother will feel comfortable and satisfied, and other medical care and other things also, that also complications also will decrease. So we should not separate this mother and baby diet. So that is the thing. Then why we should promote KMC? Not only this thing the KMC will provide, but if you see that various studies have evaluated the effect of KMC. Like there's a better temperature control. So that's the thing. Already we have seen that hypothermia, how the effects are there. And if you are putting the baby in KMC, then this how this temperature control is achieved. So that we have seen. So better temperature control if you are putting the baby in KMC, and breastfeeding also becomes better. Many studies have been conducted, so they have taken some control group and experimental group where they have given the baby or minimum 1 to 2 hours of KMC, and after that they have checked the weight gain. So in the control group, in comparison with the control group, the experimental group has the weight gain, better weight gain. So that's why the KMC has the benefit that if you're putting the baby in the KMC, then better weight gain also is there. Then less infection chances are also there. So infection chances are less. Then mortality also is there. So we have seen that so 1 degree temperature decreases means how much increase mortality rate will be there. So if you are putting, so we know that if the baby, even if the baby is in cold stress, so cold stress is the temperature is like your 36 degree to 36.4 means less than 36.5 degrees Celsius. Even if slightest decrease in the temperature, that also will have more effect. And continuously, if baby is on cold stress means again more, the baby may not gain weight and baby may have so many other complications. So that's why this KMC having more benefits in terms of temperature control, increase breastfeeding, weight gain, and infection and mortality rate also decreases. Then another benefit, what are the other benefit? Like the various parameters also establishes or the maintains, like heart rate. Maintains the good heart rate, and respiratory rate. Respiratory problem also will decrease. So if the baby is on KMC, so it will decrease the respiratory problems, and the respiratory rate also will maintain. And because their temperature maintains, that's why oxygen saturation also maintains. And oxygen consumption is less, so that's why also baby maintains the normal blood glucose level. And if you are putting the baby in the KMC, then there's a sleep pattern also will increase. The less stress will release. So the stress hormones also will be less. So if the baby is in stress, then definitely this development also has an effect on the stress. The cortisol, usually the stress hormone cortisol, if baby is in pain or baby is in stress or hypothermia, these are one kind of stress to the newborn baby. So if the baby is in stress, then definitely the stress hormone will release, and it has other effect, like it will cause more other effects. Mostly the developmental problem also, the maturity also will be reduced. So these are the different kind of benefits we can say. So it maintains the physiological parameters. Then already we have talked, but again, like better and early lactation also will be there. Postpartum bleeding, better bonding, less anxiety due to prematurity, and more sense of in the KMC. So more sense of responsibility will be there because baby will be all the time with the mother, and mother will be having more responsibility. So so many studies have been conducted. I have taken one meta-analysis. So it is done by, it was published in the Pediatrics 2016. So these are the authors. So they have taken 1,035 studies and they were screened. And out of that, 124 met the inclusion criteria. So among the low birth weight newborns, the KMC compared to conventional care was associated with 36% lower mortality rate. So conventional care KMC, so 36% lower mortality rate. The relative risk was 0.64 and 95% confidential interval is there. Again, other benefits includes a KMC decrease the risk of neonatal sepsis, and hypothermia also decreases. Then hospital readmission, increase exclusive breastfeeding also, that also increase. Then newborn receiving KMC had lower respiratory rate and pain measures, higher oxygen saturation, maintains temperature and head circumference growth. So they can maintain the higher oxygen saturation, pain measurement also, like if the baby is in NICU, so they are undergoing stressful or the invasive procedures. So the newborn also experience pain. But if you are putting the baby in KMC, then the pain will reduce. So the retinopathy, when we are going for this ROP screening, so it is a very painful procedures. So many studies I have seen that when they are conducting this ROP screening, so that time they have put the baby in the KMC and the pain was reduced. So that's why this KMC reduced images as well as respiratory rate also maintains, higher oxygen saturation also maintains, and it maintains the temperature and head appearance, the growth also is maintained. So these are the benefits of KMC. So we have seen lot of benefits of KMC in baby, mother, and physiology also it is there, and other infection control also is there, and pain measurement also is there. So that's why definitely we have to promote KMC. So which baby should get KMC, until how many days we should give KMC, all these things are also important thing. So minimum is 1 hour we can provide, maximum 24 hours we can provide the baby. And till like the baby sometimes like 34 achieving gram or less than KMC. When the baby doesn't maybe that they don't require baby not feel comfortable. So that is KMC. While if the baby is in NICU also we have to provide KMC, and normal birth also can provide KMC. Mostly the low birth weight baby and the baby is stable. In ventilator also, and the baby is in IV fluid. So some people can ask whether the baby is in IV line or ventilator or a CPAP. Can we put the baby in KMC? Or thing is that the baby should be stable. So in between in the CPAP also we can put the baby in the KMC. Mother can put the baby in KMC during that time. And while the mother is working, that time also like the mother can carry the baby in a KMC position and complete her work. And if the mother is sick also, the father and the grandmother also can provide the KMC. So definitely it is a right, we can say that it's the baby's right. We can provide the KMC to the newborn baby. And as we know that more benefits are there, that's why we have to encourage the mothers. So that's why the first thing is that preparation of the mother is very much important thing. We have to prepare the mother. Psychologically, we have to prepare the mother. If the mother is having low birth weight babies, then psychologically we have to prepare the mother that we have to provide the KMC. And again, we have to teach them how to provide KMC. That is also important thing. So psychologically as well as physically also we have to prepare mother. And we have to teach their position. And sometimes nowadays, just to promote this KMC, many hospitals separate KMC ward also has developed. So that also we have to, if it is not there also, anywhere inside the home, inside the hospital, anywhere they can provide the KMC. Only thing is that mentally they should be ready. So company should given the benefits of this KMC to the mothers, and it is no harm. And we also can encourage the mothers by showing other mothers also, by interacting with other mothers also. KMC, then definitely you can also give the KMC. Either singly the mother can give or in a group also. If in a group in a room, like separate ones there as KMC one, or then group also can provide, or we have to show them videos, classrooms, so we can teach them. In that way, we can prepare the mother and family for providing KMC. Then who will counsel this mother? Like trained personnel are there. Those are trained as a nurse. It is our responsibility to train the mother and prepare the mother regarding the KMC. We should have adequate knowledge. We have adequate knowledge regarding KMC, and with good communication skill, and we should be very conversant in local languages. We have to just provide education and knowledge to the mothers. And first counseling be done one-to-one basis. And again, if there's requirement, then we can do counseling. So public health nurse, social worker, or other nurses also can do. So, and sometimes in many hospitals, they may say that we don't have extra staff, so we cannot promote KMC. If they say like this, so no extra staff is required, no existing staff is, so along with the existing staff also, this KMC can be done. So mostly we have to teach them how to initiate, how to position the baby between and during the feed, then how to feed the baby, lower fed baby, preterm baby. And we have to involve them in all aspects of baby care. And we have to encourage the mother, support the mother and family. Family should support. Otherwise, it is not possible to provide care. Nowadays, most of the mothers are educated. They are providing, and most of the hospitals also providing the KMC. But still not giving the KMC as they don't know the benefits of KMC. So we have to promote the KMC because it has. So like how to train the mothers how to hold baby. That also we have to train. In breastfeeding, suppression also, like spoon feeding also we can tell them. So position if the mother's baby is not able to suck the breastfeeding, put the baby in KMC gradually, so the transition will happen and the growth will happen and baby may take the breast milk. So during the time, this express breast milk and this thing, the cutlery spoon feeding also can be given. So regarding the dress of the mother, the dress, no special dress is dressed. Sometimes mother will be reluctant or that I'm very sorry to provide KMC. I don't have dress. That type of questions also come from the mother. But we have to tell them that no special dress is required. Whatever culturally suitable, so that is wear, and whatever comfortable to the mother. The thing is that any front open dress, even the mother wears the sari, the blouse also, the mother can open the blouse in between the chest, the mother can provide. Or in front open dresses, 90s, and if the baby mother is in the war, so gowns are also available. That so sari, kurta, gown, night suits, anything, any dress by that also mother can provide the KMC. So that's why counseling is important thing. So no special dress is required. What kind of dress we have to provide for the baby? So baby to be undressed, front open shirt be there, and thing is that baby to wear the nappy and so face, abdomen, and legs, and that should remain in skin contact. Uh, and special sling to support the babies. So that answer, this is the way we can give. Then which area we can give? Like we can practice any area. So in the inside the labor room itself also we can start this thing. If the baby is stable, near term babies, then we can provide in NICU areas also as soon as the baby is stable. In transit area, sometimes like the mother is deliver the baby in the labor room and transferring or from the labor room to the ward, or during that transport time also mother can provide, or any transit area mother can provide the KMC. Then home also we can just tell them. So we can which position can provide, so any comfortable position like reclining chair, bed, while walking, while doing household or shopping also mother can provide KMC. So not a thing that during hospital stay or in the home stay you can provide. As the mother is walking, mother can do the household work, and during shopping also mother can provide this thing. And already have told that other person also can provide this thing, and transport also that time also we can provide the KMC. So we can have the mother through the mass media, then journals and all. As many studies have published regarding the KMC, we can conduct workshop like through different professional bodies also we can promote. And if they are not, then to just aware their mothers regarding this thing. So if you are promoting this, then definitely they'll provide KMC. So the discharge criteria is that if the baby is feeling well and in temperature, gaining it, then we can just tell the mother, the hospital, if there is in hospital, we can discharge. We have to do the adequate follow-up at least once in a week. We have to do follow-up. All the benefits, and we can say that perspectives. We can say that mostly to prevent the hypothermia and to maintain the physiological stability and increase the growth. So these are different kind of aspects for which we should promote the KMC, and it is our responsibility. So just by listening to the webinar and also we should not stop. So different modes are there, or while we are as a student we are taking care of their mother in the hospital, or as a nursing faculty or as a nursing student. So it's our responsibility to promote this KMC because it's very low cost method and inexpensive method to decrease or to gain the benefits of this thing. So I think I have covered aspects. If you have any doubt on this KMC.
Thank you, madam, for your stimulating and interesting presentation. One participant asked question, how came help in pain management in a pandemic?
In the study is seen that the pain scale is ready because if you are putting the baby in KMC position, so multimodal stimulation also baby feels comfortable and the babies with the mother and usually babies feel more comfortable with the mother and if the baby is in this position with their mother's breast, so I think that pain control theory, you can say that the theory, so the pain stimulation so is reduced, so they again your other hormones and the pain control occurs by giving this chemistry. This stress also is reduced so to the baby, and because of that also it's pain risk. Many evidence-based practice has been seen.
Thank you.
Hello.
Hello. Hope Satyarpa Sarkar. Thank you, madam. You are highlighting important point in our KMC. Now we come to the end of the session. Thank you, Madam Rupinder Devar, Madam Geeta Nayak for enlightening us with their knowledge and presence. Thank you so much, madam. Hello.
Thank you very much.
Thank you.
Thank Our heartfelt thanks to our participants for active participation. With warm words and a kind message, we move to end of today's section. Thank you all of you. Tomorrow will come 11 a.m. Hope we'll meet you again. Thank you all of you.